Hello, everyone. We'll get started in just under a minute. Okay, well, going to get started. Hello and welcome to today's webinar, Report Back from SGO, What's New in Uterine Cancer. I'm Kitty Silverman, the Uterine Cancer Program Director at SHARE. Today's webinar will focus on any new information and research advances that came out of the Society of Gynecologic Oncology annual meeting held last month. Before the presentation begins, I'd like to tell you a little bit about SHARE. SHARE is a national nonprofit that supports, educates, and empowers anyone who has been diagnosed with breast or gynecologic cancers and provides outreach to the general public about signs and symptoms, because no one should have to face breast, ovarian, uterine, cervical, or metastatic breast cancer alone. For more information about upcoming webinars, support groups, and our helplines, please visit our website at sharecancersupport.org. All participants will be muted during the presentation. Once Dr. Hoskins finishes presenting, we'll begin the Q&A discussion. Feel free to ask any questions through the Q&A section at the bottom of your screen. Remember that Dr. Hoskins is unable to give specific medical advice, so please keep your questions general in nature. We also have closed captioning available. You can enable this feature by clicking the live transcript button at the bottom of the screen and selecting the subtitle option. The webinar is being recorded and will be available on the SHARE website soon. We're very excited to have Dr. Ebony Hoskins joining us as today's speaker. And now I'd like to hand it over to Dr. Hoskins to introduce herself.
Good afternoon. Okay. I will introduce myself. I am a gynecologic oncologist. Yes, that's me. Probably 5 years ago when I had more hair, but I've since cut it off. It's the same person though. I'm a gynecologic oncologist in Washington, D.C. at MedStar Washington Hospital Center. I've been in practice for 13 years. I'm originally from Michigan and have been in the area, in the Washington, D.C. area, approximately 10 years. I'm pretty much a clinician and meaning 100% clinician, and we are working on improving clinical trial availability at our institution. Outside of work, I have one child, one husband, and we'll talk about that. Well, I guess one husband. Yes. We'll talk about that later. So I think I can share my screen now. So I will have to tell everyone that's on, I wish I could see you. I wish I could talk to you. But what my hope is that we can get through the slides I have here to share. And I know that they're not kind of the most user-friendly. So I would suggest that if you have any questions or things that's popped up and you're like, hey, I don't quite understand what that means, please jot it down. And I'm happy to go back over it if you have any questions in the chat via Kitty. So certainly I miss hearing your voice, but I think any written voice would be great. So I'm here to report back from SGO, what's new in uterine cancer. And the SGO, those who do or do not know, is the Society of Gynecologic Oncologists. I think we have about 1,300 members. It includes gynecologic oncologists, medical oncologists, physician assistants, radiation oncologists, kind of the whole slew of folks that take care of women with GYN cancers. So my objective today, so we can go through it, will be really kind of what's on the horizon for treatment. And when we talk about what's on the horizon, meaning what's coming out phase 3, and I'll go through a little bit of detail what that means. Phase 2 data, kind of what's in the pre-development, meaning it's not in patients yet. And then kind of some things that us as providers are kind of working through, which is the staging that's new. So first up, you're ready for the complexity. I'll try my best. So Ruby 1, for those who know or may not know, was a clinical trial that had resulted data at SGO in 2023. It is a phase 3. So I'm going to stop here. Phase 3 means it is a trial that has gone so far along in development, it's looking to see if the standard of care can be approved upon with the new drug. So prior to this trial, standard of care for advanced or recurrent endometrial cancer who've not had chemotherapy before was use of chemotherapy, carboplatin, paclitaxel. And then phase 3 is saying, is there anything else that we can improve upon to have improved survival? So this is looking at carboplatin, paclitaxel, and darstelamab, which is a type of immunotherapy, versus carboplatin, paclitaxel, and placebo. So essentially standard arm. And this trial went on for 6 cycles of those treatments. Patients were randomized, meaning they could either get the experimental arm versus the placebo arm. And then they went on to either continue with darstelamab or placebo up to 3 years. And the take-home point is that we looked at different markers in the tumor of the cancer to see if it's what we call MMR, proficient or deficient. So kind of in patients, we know that patients who have a deficiency in these proteins actually did even better with darstelamab, and patients who did not have a deficiency in the protein still did better as well. We always think about the side effect profile when we're adding new drugs, and we felt like they're pretty safe: fatigue, hair loss. Anemia is probably one of the bigger ones, and peripheral neuropathy, as well as nausea. And they're in both arms. So picture, confusing. But the whole take-home point in this slide is that there was an improvement in what we call overall survival when they looked at all the patients, whether they had different protein markers on the tumor or not. And so the line that we're looking at is this purple line showing that in all patients, use of carboplatin, paclitaxel, and darstelamab had an improvement in survival. And this duration of the response was up to 37.2 months. Sorry, where's my? And this is breaking it down. This is data that is breaking it down. Remember, we talked about deficient MMR and how the darstelamab, the immunotherapy, had an even greater response in this patient population. So now what I'm saying is, if I have a patient who has a tumor that either has what they call microsatellite instability or Lynch syndrome, or some of these tumor markers that are not present in the tumor, I'm now treating with carboplatin, paclitaxel, and darstelamab, and then offering a maintenance therapy, meaning after the chemotherapy part is complete, giving this darstelamab treatment every 6 weeks up to 3 years because of the improved survival benefit. So what about the patients who have tumors that are proficient in MMR? Still an improvement. It's not as high as the tumors without the deficiency, but it shows less. I'm sorry, still overall improvement in overall survival. So that's Ruby 1. Now, the second trial, which is very similar, this one is called NRG-GY018. And the main difference between this trial and the trial I just spoke about is the previous trial included tumors such as carcinosarcoma, which can be a rare but yet aggressive histologic type of endometrial cancer. So phase 3, similar thing, what I explained before, phase 3, carboplatin, paclitaxel, except this time it's pembrolizumab. And pembrolizumab, you may hear it on TV as Keytruda, that's that drug, versus, again, carboplatin, paclitaxel, and placebo. And it's very similar, again, in terms of how it's administered, but the inclusion criteria in terms of the histology is a little bit different. But again, these data are still maturing, but their overall and progression-free survival showed an increase. So again, this is breaking it down. I'll move this, showing improved progression-free survival. And here they're looking at to see whether the tumor had a marker on it called PDL1. So ready for the science? Pembrolizumab blocks PD1, which blocks PDL1. So long story short, it really didn't matter whether the tumor had the marker or not. They showed improvement. That's the total take-home point. And when I say improvement, I mean the progression-free survival. So you're like, what does that mean? Meaning how well patients did without having, how long they went without having any increase in the disease on imaging. So again, prove, sorry. And so this is, I think my slide is a little messed up, but I'm just showing here, pembrolizumab improved progression-free survival regardless of whether the PD-L1 marker was present in the tumor or not. Okay. Remember, I talked about the first trial being a phase 3, and it's part of the Ruby trial. So Ruby had something called part 1 and part 2. And so at SGO here, they talked about part 2. So the part 2, and this kind of goes through what I talked about before, but this part of the trial looked at, again, same patients. Patients had stage 3 or stage 4 or advanced disease or a first recurrence, and they looked at all histologies. And when they say sarcomas, they mean carcinosarcomas, not uterine sarcomas like the traditional uterine sarcoma. And these are kind of the inclusion criteria. Now, I think my next slide, I go through it, but I'll go through it a little bit on the other end. This again looked at carboplatin and paclitaxel with that immunotherapy. But then for maintenance, they added not just the immunotherapy, but a niraparib, which is actually a drug, a PARP inhibitor that we typically use in ovarian cancer. So I think what the clinical trial, what they're looking at to see, is there an improved survival benefit by adding not only darstelamab, but niraparib versus looking at patients that had the carboplatin, paclitaxel, and placebo, or just placebo and placebo. And this showed a statistically significant progression-free survival with the use of darstelamab and niraparib. Now, I would have to say I'm a little biased, and I don't know if I've thought about adding this to offering it to my patients at this point, because it doesn't really show us what happens. They already showed us that if you have darstelamab alone, there's an improvement, and I would have loved to see what it looked like without adding that PARP inhibitor, because that drug can be a little bit toxic in terms of side effect profile. But they show an improvement, and I'm just here to present it. Okay. So I wanted to just kind of let you guys know what's kind of coming down the pipeline. Is the use of looking at, again, like I said, PARP inhibitors are drugs that are used typically in ovarian cancer that there has been some new studies coming out looking at it in endometrial cancer. It is used, just so you know, as a maintenance drug. It can inhibit cancer cells from repairing itself, which results in cell death. There's limited study in the lack of arm, like I just said before, and then the side effect profile. Probably the biggest that I've seen with use of it in patients with ovarian cancer is really it can kind of knock down the blood counts, such as the hemoglobin, platelets, and white blood cell count. I've even seen it impact kidney function and fatigue. So, before adding an additional drug, I certainly want to see that it shows a benefit. Again, these trials are fairly early on, and we need to kind of continue to follow to see, mature data. So this slide is, again, just what I just mentioned, kind of what are the side effects. So these are what they call AEs, or adverse effects. The main way to look at it is side effects. And typically anything that's a grade 3 is something where the doc or we would have to either stop the drug or hold the drug or reduce the dose. So when you see these darker, it means when they use say niraparib and darstelamab, it's a little bit higher. Anemia so much they probably even had to hold blood transfusion, etc. And that's kind of the biggest thing that I see. They say anemia, but I think that includes all kind of myelosuppressive, meaning bone marrow. Okay. So new drugs that are on the horizon. I have to admit, I'm quite excited about these new drugs that are on the horizon. They are currently clinical trials that are enrolling. So we don't have a lot of data on the new, like we have at my institution, two trials that offer these antibody drug conjugates. And so the amount of, phase 2 data is still accruing these patients into it, but this is early. So let me just give you a background what it is. These are a new class of drugs. So when we say chemotherapy, we mean drugs that are toxic to cells that kill not just only cancer cells, but they also can kill normal cells. Killing the normal cells is what causes side effects like anemia, hair loss, GI upset. Those are things, and they're kind of non-specific. Whereas an antibody drug conjugate, the goal is to be more specific and target cells or antibodies or proteins, if you will, that are specific for cancer. So antibody drug conjugates, they typically have a monoclonal antibody towards a specific target on a cancer cell. So that's the antibody. And then there's attached to a drug and what they call a linker. They're new that are on the horizon. And our reason we like it is that it can target a cancer cell and antigen while not harming healthy cells or having less harm to healthy cells, that there is a strong drug conjugate and high toxicity to cancer, to an actual cancer cell, and it can go inside the cell and kill inside the cell, and that it is a stable linker. So remember, we got antibody drug conjugate that can release into the cells, and then that it can focus on specific cancer cells and reduce side effects. So the one that was presented at the Society of Gynecologic Oncology is actually currently FDA approved in breast cancer. So there's been use in the drug already. It's not a novel drug at this point, but novel in the GYN cancer world. And the name of this study is called Destiny Pan Tumor 02. And it looked at endometrial cancer, ovarian cancer, and cervical cancer that express HER2. And in this particular trial, the tumors had to have HER2 plus 2 or HER2 plus 3. I'd be honest, it was very exciting to me because they demonstrated a response in all endometrial, cervical, and ovarian. But in this talk, we're going to emphasize the uterine. So they demonstrated an overall survival in all patients. But you can see here, the way we're going to look at this is all patients, the response rate was 57.5%. I would say the average kind of second line treatment, if you will, for uterine or endometrial cancer particularly is like 30%. I think Pembro-Lenvima is like 40%. So now we're like actually making headway, in my opinion, with having improvement in disease response. And you can see the patients that had patients with tumors with immunohistochemistry that's +3 had an even better response with 84.6%. Those that had +2 had a 47.3. Less than, and it's just interesting, I can't explain it, but if it was more than 2 prior regimens, then the response to this drug was even better. And just for information purposes, even the response rate in these HER2 positive cervical cancer and ovarian cancer were again great, even best in uterine. So this is certainly a drug. I believe it is currently on the National Comprehensive Cancer Network guidelines, but it's not necessarily FDA approved in endometrial cancer. So, some providers try to get it approved through the insurance and see if they can go that route to use it. I think certainly exciting in my opinion. And then we obviously, anytime we introduce a drug, we have to look at side effect profile. So one of the big, again, looking at the darker line is grade 3. Typically grade 3s, again, is going to cause us to either hold the drug or dose reduce. And most likely not necessarily discontinue. And obviously we have to kind of take it on a case-by-case basis. But neutropenia seemed to affect about 20% of patients, anemia, I should say severe neutropenia, but the highest was nausea and fatigue, diarrhea. With the ADCs or the antibody drug conjugates, there is increased risk of pneumonitis, which is kind of a autoimmune response to the lungs and can result in shortness of breath and other side effects. And it is taken very seriously because anytime you see a grade 5, that means a patient died. And so even though the number may be low, we obviously have to always kind of keep an eye out and look very closely at patients and how well they tolerate the drug. And obviously we want to be safe and have a good quality of life. Okay. So new drugs on the horizon. I thought this was interesting. So I'm sure you have heard of the newer drugs, GLP-1 inhibitor. I'll click on it next, which would be like your Ozempics, and they've caused some weight loss. So this is one of the drugs, tirzepatide. And the whole point, this is a GLP-1 glycogen-like peptide 1 inhibitor, as well as a gastric inhibitory peptide receptor agonist. Long story. It's going to improve, it says insulin secretion and glycogen secretion, decrease gastric emptying, appetite. So these drugs that's new on the horizon is going to basically treat obesity. And as you may or may not know, endometrial cancer is linked with obesity approximately 65 to 70% of the time. So this is preclinical data, meaning it hasn't been done in humans, but this is done in mice. And so their model is they had a mice model that had some were lean and some were obese. And then they use the injection of these drugs and they sacrifice. And they also, these mice have an endometrial cancer model. And they basically treated with the drug and looked at it. And they found that the mice that had this tirzepatide treatment resulted in less weight overall and less tumor weight. They also looked at the tumor itself and saw decreased proliferation. That means growth, if you will, of cancer cells in the mice tumors. And when we say pro-apoptosis, it means cell death, meaning like the cell death. So it was pro-apoptosis, meaning increased markers noted when they treated with this treatment results, suggestive that this may be an innovative strategy in treatment of obesity-related endometrial cancer. So again, it is not out on the market, if you will, but it's preclinical and just kind of treatments that are on the horizon. So what else is new? Well, you want to be more complicated? Okay, so if this is complicated, it's going to be complicated for you because it certainly is complicated for me. For many years, we have memorized, if you will, what endometrial cancer staging is. And the way I always thought about it was stage 1, disease confined to the uterus. Stage 2, cervical involvement. Stage 3, you can have involvement of the vagina, the adnexa, meaning the ovaries and fallopian tubes, and or lymph nodes. And then stage 4 can be extension from the bowel or bladder, and stage 4A is bowel and bladder, and stage 4B would be distant metastases, meaning spread to the liver or lung or somewhere outside of kind of the pelvis. Now, in 2023, the FIGO means the Federation of International Gynecologic Oncologists, changed the staging. And I think the point in changing the staging was to take into account not just the anatomy, but the actual histology in terms of prognosis. And listen, it's no longer based off of the location. I mean, location, yes, but now we take into account, the histology in terms of like stage. So I know these are really small letters, but just for you to look at, stage 1A, again, confined to the uterus. But if it's a more aggressive subtype, even though it was like confined to the uterus and not invading, it can be automatically upstage if it were, say, a serous carcinoma or a carcinosarcoma. And then now what we're doing now is more molecular testing of the tumors, meaning we're looking to see if there are any genetic changes or protein changes, and that will help us with sometimes treatment and sometimes prognosis. And the take-home point from the SGO is that, yes, we have new staging by FIGO, but I would have to say the overwhelming majority of the participants who were of US or like there were international participants there at the conference, but I would say most docs have not transitioned to this new staging. So there was a lot of debate about when we would change. Does that impact treatment plan? Kind of what do we do with it? And I think that's the take home point, is that I still stage off the 2009 staging, keeping in mind the 2023 staging. And I don't know when we will fully adapt, but it's certainly something to be aware of. Okay. And this kind of goes through a comparison. Just to give you an example, let's see, oops. I'm just going to move some stuff around. Yeah, it just says confined to the uterus, uterine corpus, now defined by the combination of the histologic type, mild mitral invasion, absent, or focal LVSI. So I would say when we're seeing final pathologies after surgery, we do need to pull out kind of our books, if you will, and stage. And again, I have not fully adapted the FIGO 2023, however, aware of it more from an academic standpoint. And then we're going to talk briefly about diversity in clinical trials. And then I would like to open it up. I think I'm probably ending a little bit early, but I certainly want to kind of get into a discussion, like I said earlier. So I thought this was interesting. This is diversity in clinical trials, but one of the participants at the SGO presented this data just showing breast versus gynecologic cancer survivors. And it's certainly a different number. And I think when you see a different number, the amount of funding is different, and maybe that makes sense. But I think in the breast cancer world, there's been significant amounts of improvement in treatment options and survival, whereas in the GYN world, we're a little behind. And when you see this next slide, you'll see why. So breast cancer survivorship predominates grant funding. And I think when we say grant funding, we're talking about US, like NIH funding, big grants, 148 versus 11. So 11 grants, higher total cost per study and survival for breast cancer versus gynecologic cancer. And one of the unmet needs that they said was gynecologic cancer survivorship research and support. And then I definitely think that this is a good time to talk about, clinical trials. Me personally, I serve a underserved population in the Washington, D.C. metro area. We certainly see lots of women with advanced endometrial cancer or like early endometrial cancer, but higher histologic grade, and find that and so I know that their marginalized patients have higher cancer incidence and mortality rate, and unfortunately are underrepresented in clinical trials. And we always say, why? Well, why do you want to do a clinical trial? One, this is how we know what is improving survival, right? So I just showed you data to support why we are using immunotherapy. Had we not had participants in that trial, we would not know and have improved survival. So this is the way I look at it, and at least should offer it to my patients, and at least offer it there. So, and as we've done these are not my slides, but I've done my own and looked at, they say only 9% of patients are actually informed of a clinical trial. And I would have to admit, I was guilty of not offering it. And I think the reason why was, well, I didn't have it, so why offer it? But I also think that this is opportunities that sometimes I may not be able to offer it, but that doesn't mean my patient doesn't deserve it. So listen, be informed, ask questions, inquire about trials. And then up to 2/3 are willing to enroll trials, but they're just never offered, including Black patients. And there's some structural barriers for lack of participation. And then these are things that why they're important. It improves the rigor. It improves generalizability. It's an opportunity to get standard of care and cutting edge treatment, and then innovation. And then I would have to say that a lot of the trials, especially the phase 2s, are actually funded by the sponsor. So in terms of cost, it may be something to think about. Okay, that's the end of my slides. I would love to open up for questions, Kitty, and we go from there. I'm going to write them down in case we have some hard ones.
Oh, okay, absolutely. Thank you so much, Dr. Hoskins. That was done in such an understandable way. It was really great. Thank you. Yeah, I'm going to just, we're going to start the Q&A. There were a lot of pre-submitted questions, and you can still submit through the Q&A, which is at the bottom of your screen, and we'll try to get through as many questions as we can in our remaining time. Just one quick thing to note, we're focusing today's Q&A on research updates and new developments in uterine cancer, and we did have a number of pre-submitted questions related to surveillance, specific treatments, and things of that nature. So I just wanted to refer everyone to a great recent webinar we had several weeks ago about moving forward after uterine cancer, about surveillance strategies, testing, recurrence, et cetera, which covered a lot of those questions. So you can access that video through our video library, and we'll put the link in there. So now I'd like to start the Q&A. Dr. Hoskins, I thought this was a great question. Some of these were pre-submitted. What is the best approach to treatment planning that allows the patient to take advantage of the latest research if needed?
So you said what was part of the treatment planning?
Yeah, what is for the patient, what is the best approach to treatment planning that allows the patient to take advantage of the latest research if needed?
I think that's what I hear initially in that question is being an advocate for yourself. That's the first thing I hear. And so I would say your doctor may not be one that's thinking about a clinical trial. And I think it's an opportunity, if it's something that you want to participate in, ask. And ask up front, and not just ask, but make them find the trials for you. But I think it's, bringing it up front, like, hey, I'm interested in a clinical trial as a potential, and it may not be the right time, if you will. Maybe it's not opportunity. It depends on kind of the stage, the whole clinical scenario. But I think bringing it up is the key.
That makes a lot of sense. Thank you. Now, these questions, a couple of live ones I'll switch to.
Yeah.
Somebody asked, and you covered, I think, those first 3 trials, so I may get the name wrong. The one that did not have the patients with carcinosarcoma, would they ever rerun the trial for patients with carcinosarcoma?
My guess is no. It looks at like these trials when they come out, they're literally like 5 years ago in terms of when they were development. I would guess no. I think we're going to have to follow the durvalumab trial in terms of inclusion with immunotherapy. Now, some of the trials that are going forward now are taking all types. So I would say going forward, because just as a little background, carcinosarcoma, maybe in the last 5 or 10 years it was thought to be a sarcoma, so not listed as an endometrial cancer. So now it's gone back to being listed. And so I don't know if that is a factor on why they exclude. But I would say at least the trials that we have open now are all comers endometrial cancer, whether it's carcinosarcoma or not.
Thank you. From a patient perspective, at what point would you be looking at a trial? Post frontline, but NED, or at recurrence? What would be the point that makes the most sense?
Well, I think, right now, I don't think there's any kind of frontline, but asking about frontline, NRG 18 and Ruby 1, Ruby Part 1 were frontline clinical trials. There is one other one that's actually open now, NRG GO 26. So there's different trials. I think you can ask upfront. A lot of the upfront trials actually include maintenance. So I would say asking upfront before starting chemotherapy or at a recurrence, that's when I would strongly encourage to ask about trials upfront. And then they can look up and see if there's anything open, because what may be open today or closed today, maybe a new one's open tomorrow. And I don't know all of them, but in case you guys don't know, clinicaltrials.gov I think it's based out of NIH, and you can search what trials are available based off of tumor type.
Okay, thank you. I'm so glad you talked about the FIGO because I know that's been something that people are extremely interested in. And I have a couple of questions here related to that. How do you think the updated FIGO score, if that's the right word, will impact health plans coverage of gynecologic cancer, especially for immunotherapy?
I think it's to be determined.
Mm-hmm.
That's what I would say. Because even now, again, the adoption of it, even though we follow FIGO, the FIGO staging, it hasn't really been readily adopted. And I don't know if they'll go back and change it, quite honestly. I don't know where we are with that, but I would say no, not at this point.
Okay. And if one was staged initially,
Do we
should
change the stage?
yeah.
No, we don't change, but I did a talk in January, and it was just very interesting because just looking at one of my patients, she spoke there, and I looked at her stage compared to her stage when I think we used the 2009 versus the 2023. She would have gotten, in my opinion, upstage, and I would have treated her differently. But we can't go back because that's not what we didn't know that, right? What we know different now is that P53 mutation is kind of a more aggressive subtype of a FIGO grade, so it's hard to kind of go back and be like, I'm going to restage her because now she's since recurred, but we didn't know that.
Right.
So I think, we're going to be there. I think we're going to be there because now I look at it and I'm like, wow, if I would have known that, maybe I would have treated different. I can't tell you what the outcome would have been.
Sure. Okay, thank you. Was there anything presented at SGO about new uterine cancer basket trials?
New uterine cancer
basket trials?
Oh, I think nothing presented. There's things on the horizon though.
Oh, okay.
Mm-hmm.
Okay.
There's one now that's like, oh my gosh. So just so you know, there is a trial that's open. It's called AFT 50. And it is a biomarker trial. And it basically is looking at each tumor and kind of assigning based off of the tumor and the proteins that are present. And they assign the cohort based off of the tumor. And then there's so that's one that's kind of ongoing. We don't have any data yet.
Okay, thank you. I had a number of pre-submitted questions about some of the rarer, more aggressive types of uterine cancer, carcinosarcoma, clear cell, also serous. And I think all of those were covered in the trial data that you mentioned. Do you see any new advancements down the horizon in terms of some of those rarer cancers?
I don't see any, most of them include all. I don't think, at least the ones that are coming down the pipeline, I see it's not like, okay, this is only for clear cell. And, the biggest thing that I would say, it's hard to accrue those because they are rare. So right. I think most are going to kind of include all of them and do sub-analysis. Like the Ruby trial only included like a 10%. And I don't know why they capped at 10%. I can't tell you why, but I think it would be hard to accrue a trial on rare tumors.
Right, right.
Take a long time to accrue.
Sure, sure. Okay, thank you. Now this, I think, and please correct me if I'm wrong, is a question that's related to that medication you were talking about that I'm not sure I can pronounce, the terzepatide.
Yes.
This person asked, before seeing your presentation, this was pre-submitted, is anyone using or testing metformin for uterine cancers? And I think that's in the same, is that the same type of medication?
They're different class. But I don't know that offhand. I mean, they may be, I just don't know. They definitely didn't present it there. But
Oh, okay.
yeah, I don't know that.
Okay, thank you. But that was very interesting what you were presenting about the other.
I thought it was exciting. I'm like, that's kind of cool, you know?
Yeah. Yeah, that's great. It's really great. Okay, I'm going to go back to some more live questions. Can any of these drugs, I think they must be talking about some of the new ones you might give, or maybe they're talking about immunotherapy, or
right. I got it.
Dostarlimab. Can they be taken while using Herceptin?
You know, so we always go back to our trials and say, okay, I don't see any of the trials. The ones with Herceptin are carboplatin, paclitaxel, Herceptin, and then Herceptin maintenance. But I don't see them in conjunction with Herceptin and immunotherapy. And I haven't seen anything presented, and I don't see anything in the pipeline. And I'm sure there's a scientific reason behind that. I'll be honest, I don't know. But I know that I don't think it's anything that's ongoing.
Okay. Somebody mentioned they heard there's a trial for Enhertu plus olaparib starting or started.
Let me see what Enhertu is, because I don't know that drug offhand. It may be Enhertu. If it's, because there's some Enhertu. Oh, yes, I believe so. Good question. I don't have it covered, and I don't want to tell you wrong stuff.
No problem.
I don't remember them presenting this, but it may be a trial that's ongoing. So the other question I think that person asked, can pneumonitis be prevented, or is it a case you get? Yeah, I think it can't be prevented, but it can be picked up and not worsened, meaning stopping the drug.
Okay. And I guess this relates back to Ruby and NRG 18. Does carboplatin dostarlimab, how does
paclitaxel
compare with carbopaclitaxel and Pembro?
I think they're very similar and compare in terms of side effect profile, or like how. So I can't answer that, because that means you would have to have a trial comparing the two arms. So I would say in terms of like looking at them separately, they have very similar side effect profile. I will say dostarlimab is not, like, for example, for our institution, it's not on formulary. And I think mainly it's been, well, I can just use Pembro, except until most recently, except until the patients with carcinosarcoma. And I wasn't entirely convinced, and I don't have that data presented here. I didn't know. I was like, well, how do we know, some of the earlier data that they presented was like, how do you know that the dostarlimab is making a difference in patients with carcinosarcoma? And I did see some slides, they were not presented at SGO, that showed that there may be a benefit with use of it. So I've asked for it to come on formulary. I don't think I can just say, oh, it's not helpful. I think it may be helpful. So we're asking for it to come on formulary. But I think in terms of side effect profile, they're very similar. But it's not FDA approved in proficient MMR endometrial cancer. That's another limiting, kind of a dilemma. It's a little bit of a dilemma. So I'll kind of when I say dilemma, doesn't mean it can't be done. It just means we may have to fight to get it approved.
Okay, thank you. Somebody's had a cancer where they've been treated with Keytruda, and they've had their third recurrence. Is there something after? Well, you have talked about dostarlimab, but I think their question was after Keytruda what? But I think we talked about some of the things that will be down the pike. But if there's anything else you want to add to that question.
Where is it on the live question so I can see?
This was actually a.
Oh, okay. Sorry. Say it again.
I think they're just wondering for a third recurrence of disease, and the Keytruda, they've reached kind of the point where the Keytruda is no longer effective.
Then I think this is a good time to consider a trial.
Right.
Because I think any standard treatment is going to be chemotherapy.
Right, exactly. Okay, no, that makes
sense. So
sense.
Chemotherapy meaning Doxil, and we know the efficacy of that is not great. This is the whole why, I think this is why it's exciting, because we have had improvement with agents to offer, right? And so there's actually, when I first became in this as an attending, there was the second line was already like, as soon as the second line failed, the first line failed, it was kind of no other options or very minimal options. So the fact that we have trials that are available and that are accruing with the ADCs and other agents is exciting.
Yes, no, that's terrific. Thank you. Somebody's asking if there's any recent research in uterine cancer in the PIK3CA pathway.
Mm-hmm. There's I can't remember what trial, but there is an open trial with that pathway.
Oh, okay. Great to hear. Okay, these were some more about
these are great questions. I'm like, whoa, this crowd is very educated.
Yes, absolutely. Somebody actually, this is a little unrelated, but not totally. What is the current use of pelvic washings in treatment recommendations? Is using hyaluronic acid contraindicated in cancer?
Washings is not part of the staging, but strongly encouraged. It's more of a prognostic factor. Mm-hmm. So I collect them. But what I find is when I do see a positive washing, usually that correlates with disease being outside the uterus already. So yeah, it's more prognostic, but doesn't change the staging.
And I think there was a question pre-submitted, which I found very interesting about, are there any, also a little bit off topic, but we'll go there for a minute. Are there any recommended screenings for uterine cancer for breast cancer survivors other than routine gynecologic exams, if you know?
No, I guess you mean if a breast cancer survivor is taking tamoxifen?
Yeah, that's probably
right. I think it's funny because you can do transvaginal ultrasounds, but the transvaginal ultrasounds can show a thickened lining, and that can be just associated with use of tamoxifen. So certainly being attuned to like abnormal uterine bleeding, and obviously having the pelvic exam, there's no screening per se. Mm-mm.
Okay. And we talked about that. Okay, let me just see what else. Let me just go back to some of these. Give me 1 second. So we talked about rare cancers and okay. Did the results presented at the meeting clarify the optimal duration of maintenance immunotherapy? I think you talked about the
trials are written. They're already kind of pre-written. So I think the Ruby maintenance was up to 3 years, whereas for NRG 18, it was 84 weeks or almost like a year and a half. So again, when we present the data is not mature. I think they're like 30% maturity rate. So we still need to wait till we have kind of the final outcome.
Right.
But it won't change because that's how the trial is written. Say 3 years.
Okay.
Or up to 3 years.
Okay. And I think, somebody who was high risk wanted to high grade, high risk. And they just, the chemo was the initial treatment. Would somebody in that situation potentially advance to some of the treatments you were talking about, or would there be would it be after they had a recurrence, or at what point would they be monitored more closely?
I'm sorry, what was the first question? The first?
They were somebody who was diagnosed with a high grade, high risk uterine cancer, and they did do the chemo.
Okay.
And I think are wondering if they should have advanced to any kind of other treatment because they're a higher grade, or should they, well, if there is a recurrence, that would happen.
I would say routine surveillance.
Yeah.
At this point, and routine surveillance, and if something comes up, obviously that may be an opportunity to explore trials or different treatment, but hopefully not.
Right, absolutely. And we did cover a lot about surveillance in this previous webinar that I was referring to. And I'd just be interested, Dr. Hoskins, for your practice. Do you base that on a strict protocol, or you look at it case by case? What type of surveillance is best for that particular patient?
I typically, obviously when we practice medicine, we practice based off of our education, experience, guidelines. And so there's no strict guidelines on surveillance, but I do follow one of the Society of Gynocs kind of recommendation for surveillance. And when they say just surveillance, they look at like, if I get a CAT scan every 3 months, is there improvement in survival? Or is it really just making our patients nervous and anxious and more costs? And so I typically go by, continued surveillance based off of their stage and grade and risk. So a patient who's high risk, who comes off chemotherapy, I typically see them every 3 months after they have had systemic treatment. And that means we talk about signs and symptoms of recurrence. We do, an exam. And then if there's I always kind of like, if there's any question, I have no problem scanning, but I'm not one that offers scans every 3 months. That's and that's really kind of not just based off of my own, but just some other data that was presented through the Society of Gynecologic Oncology that show that, either you have, you find things that are not recurrence, you increase anxiety for patients.
Right.
And I think I find, and then I have some patients who really want it more often, and I'm okay with doing that. But after we kind of get a year or two out where the risk is less, particularly after someone's gotten, say, chemotherapy or needed some adjuvant radiation, then I definitely do less frequently or none at all.
Thank you. And this was a nice comment and question kind of all together. First, to say to you from someone on today, your patients are really fortunate to have a physician who attends the SGO conference and can make informed decisions regarding the most suitable treatment or medications and for their conditions. And as someone who has been recently diagnosed, they write, with a gyn cancer, should they inquire whether their doctor attends the conference and feel confident that they'll assess their particular condition and recommend the most appropriate treatment and drugs?
You can ask if they're a member. I would say that I would stay away from like whether they attended the conference or not, because sometimes we can't attend every conference.
Sure.
Or some people do it from home, but are they a member? You could ask that. And then I think a good question to ask is, if you're recommended treatment, to ask, hey, where did you derive your plan? There are some people who derive their own plan.
Right.
And I try to like pull out a plan. Hey, I got this plan based off of our National Cancer Center guidelines to show that I'm giving or providing standard of care. Or, hey, this is a new paper that just came out, when NRG or 18 came out. Hey, this just came out. This shows there's some improvement in survival, and show that, showing that at least the doctor is up to date on new treatment, that they're following standard guidelines. And if it's kind of, they're not able to kind of back it up, that I would question.
Mhm. That
And you
makes
don't
sense.
have to, I always put it out there, you don't have to keep going to them if you don't like the care, right? I think some people feel like, oh, I'm going to offend the doctor. No, it's your body and your life.
Absolutely, absolutely. And I know you referred to, there's been, a lot of progress with uterine cancer treatments in the last 3 to 4 years, and it feels like it's really going in a good direction.
I think so.
Right? Yeah. So I think that's very exciting. And I know I've been to a few conferences and heard how excited people are about all the new possibilities and treatments. So I think we are going to wrap up. Thank you so much, Dr. Hoskins. This was so interesting, informative, and wonderful. And we really appreciate your taking time today. And thank you to everyone who submitted questions. And please make sure to check out SHARE's upcoming educational programs and support groups, and follow us on social media as well. And we've also included the link to our video library, which I referred to earlier, where you can find recordings of all of our uterine cancer webinars. And there's some really, really great information like today's program on there. So I encourage you to watch those. And please take a moment to complete the survey at the end of the webinar. The survey will show up in your browser when the webinar ends, and the link will also be in the follow-up email. And all surveys are anonymous. And this concludes today's webinar. And thank you very much for joining us. And wish everybody a wonderful weekend.
Thanks, everybody. Have a good weekend. Bye.